Good evening everyone, I'm Sushmitha Priyadarshini. I'm an audiologist at Bangalore Hearing and Implant Institute. My today's presentation is Otoacoustic Emissions in Daily Audiological Routine. Otoacoustic emission is an electrophysiological test that records outer hair cell functions. Otoacoustic emissions are sounds that result from energy generated in the cochlea that are propagated through the middle ear and into the ear canal, where they can be measured using a sensitive microphone. So microphone is kept inside the ear canal, and the sound which generated in the cochlea, it passes through middle ear and to the ear canal. This will be recorded by microphone. OAEs were first described by David Kemp in 1978. And since that time, otoacoustic emissions have become a standard part of the diagnostic test battery and a screening for hearing loss. Hypothesis of OEE generation and their relationship to auditory function. The traveling wave and the cochlear amplifier. In active biological mechanisms, cochlear amplifier are believed to be responsible for the nonlinear characteristics of cochlear responses, as well as the exceptional sensitivity and frequency selectivity seen in a healthy cochlea compared to damaged cochlea. So the cochlear amplifier is hypothesized to contribute additional energy that enhances the vibration of the basilar membrane at the peak of traveling wave, particularly at low stimulus level. So the outer hair cells contribute more to this process. Sealing of the ear canal by the probe is very important, which increases the sound pressure below 3 kHz while recording OAE, as otherwise drum vibrations would simply move air in and out of the ear canal. Although OAE are a good indicator of hearing loss, it is not a hearing test, it is a test of an essential and vulnerable cochlear function. Historical perspective, otoacoustic emissions mean the emission of sound energy from ear which can be detected at the eardrum by a miniaturized sensitive microphone. Cotton and Strauss 1994 defined OE as the sounds generated within the cochlea by the outer hair cells which can be detected at the tympanic membrane. Initially OEs were unbelievable fact because one can never think that eye can produce light or nose can produce smell. Then how it is possible for the ear to produce the sound energy? Early contributions to the OAE. Before the time of Kemp or Gold, it was found that our ears generate sounds. In 1700s, Giuseppe Tartini recognized that the presence of audible notes are not being produced by violin when he was playing double stop trill, where the performer plays two notes simultaneously, often in rapid succession. He concluded that these notes must be generated within the ear. Among musicians and scientists interested in hearing these extra sounds is known as Tartany tones, presently described as distortion products OEEs. David Kemp, discoverer of OAEs, in the mid-1970s, Dr. Kemp conducted a series investigations on basic cochlear functions that confirmed the presence of active mechanism that could produce energy. In 1978, he showed that following stimulation with tones or clicks, additional sound could be measured with a small microphone in external ear canal of animal models and humans. Why OEEs will never replace the audiogram in estimating degree of hearing sensitivity. OEE is inward and outward propagation at low energy signal. Where the signal enters, it echoes back. In audiogram, it is inward propagation only. Where the signal enters, it absorbs. OEE sees outer hair cell integrity, where audiogram sees both outer hair cell and inner hair cell integrity. OE is purely sensory, which is pre-neural. It doesn't records any neural activities, whereas in audiogram it assesses both dependent on eighth nerve and central auditory nervous system. OE is abnormal with any outer hair cell dysfunction. Audiogram is normal despite low percentage of outer hair cell dysfunction. OE is electrophysiological test. Audiogram is behavioral test where it involves subjective responses. OAE measure outer integrity, where audiogram is a test of hearing. Origin of OAE is cochlea, where studies shown that there are agents that damages the cochlea will reduce or eliminate the OAEs. Such agents are loud noise exposure and ototoxic drugs that reduces the amplitudes or eliminates the OAE responses. The generation of OAEs on physiological basis involves external ear canal, middle ear, inner ear or cochlea, efferent auditory system. External ear canal plays a major role in stimulus delivery, and while recording OEE, it acts as an interface between auditory system and measuring apparatus. That OEE probe houses one or two signal delivery tubes that are connected to miniature speakers, as well as one or more microphones that collectively record the acoustic signal at ear canal. And the probe tip has to be fitted properly, otherwise the leakage happens and it might block the signals going to the ear canal. The autoacoustic emission pathway is shown, where it has two speakers which produce the sound. It passes through the ear canal and middle ear and it reaches the cochlea. In cochlea, the intermodulation product occurs and it goes back to the middle ear and ear canal, and this will be recorded by microphone. Middle ear also plays a vital role to generate OAEs in transmitting stimuli to the cochlea from ear canal, and this OAE generated travel back from cochlea to external ear canal via middle ear. So the middle ear had developed as an impedance matching device for coupling sound in external ear to the cochlea. So in cochlea, normal functioning of outer hair cells are essential for generation of OAE. In the cochlea, the electrochemical gradients which are essential for normal outer hair cell function is maintained by stria vascularis. When the energy from sound source reaches the cochlea and moves the basilar membrane, a series of events occurs within outer hair cells. This begins with straightforward deflection of stereocilia on the top of outer hair cells. This leads to the opening of ion channel and depolarization of the cells. So during depolarization, hyperpolarization of the cells, the size and length of the cells changes, leading to vertical movement, which in turn fed into basilar membrane, enhancing its motion and leading to greater hearing sensitivity and frequency selectivity. The stapes footplate at oval window vibrates and communicates with cochlear fluid. This applied pressure at oval window leads to communication of scala vestibule and scala tympani at helicotrema. This anatomic features result in expansion of round window membrane into the middle ear space when there is an inward push of stapes footplate. This also creates a pressure difference leading to movement of cochlear duct and setting series of electrochemical events that lead to the generation of OEEs. The fluids present in the scala vestibule and scala tympani and scala media is differed by chemical composition, turns out to be a crucial in powering the active amplifiers believed to be driving force behind OEEs. The fourth anatomic system is efferent auditory system that involves OAEs, and the efferent auditory system descends from the brainstem to the inner ear, where it exerts inhibitory influence on cochlear activity. Distortion of the traveling wave. Simple linear passive versions of the cochlea will not re-emit the sounds, it gets absorbed, and changes is seen if the traveling wave gets distorted, and distortion exists in various forms in the cochlea. And the classification of OEs is based on stimulus, whereas the four types, spontaneous OEs, there is no stimulus required for this, and approximately 60% of prevalence is seen in normal years, and it's limited usage in clinical setups. And transient evoked OEs, they use click or tone burst stimuli, and 99+% of prevalence in normal ears, and this will be used in clinical setup. A distortion product OAE uses 2 pure tones and 99+% of prevalence in normal ears, and this will be used in clinical setups. But whereas stimulus frequency, it uses continuous pure tone, and there is no prevalence, unknown prevalence, and there is no usage in clinical setup. Spontaneous OAE are low-level tonal signals measured in the external ear canal in the absence of any known stimulus. They are usually inaudible to the people, and if SOAE is present, it suggests that cochlear hearing sensitivity is normal, and it also provides information on cochlear functioning and offers a useful tool for studying a number of cochlear mechanisms. This cannot be used as a clinical tool since it is absent in 50% of normal hearing sensitivity individuals. Recording of SOE is done by coupling microphone to the external ear canal, and to eliminate the physiological noise below 300 to 500 Hz, the noise in the ear canal is pre-amplified and high-pass filter. So the signal is then delivered to a spectrum analyzer for spectral analysis. To reduce ambient environment noise, the test room door has to be closed, and the probe tip has to be sealed properly, and the patient has to sit far away from the instrument, and turn the patient so that test ear is facing away from the instrument. Increase the amount of signal averaging. If these steps are inadequate, relocate the patient inside a sound booth. To reduce physiological noise for older children and adults, instruct them to remain sit still and limit movement. And for younger children, amuse and distract. For infants and children which is difficult to test them, perform under sedation. Stabilize the cord from the equipment to the probe tip to minimize rubbing on the table or chair. Increase the amount of signal average. The factors affecting SOEs under subject-related factors, ear and gender effect. The prevalence of SOE is higher for the right ear than the left ear, and number of SOEs per year is more for left ear in both adults and children, and larger SOE amplitude is seen in right ear than for females than the left ear and male. Age, with the development of age, the children prevalence, number, year, amplitude level and frequency of the individual SOEs decreases from neonates to older children, and SOE in children is more prominent at high frequencies and adults more prominent at mid frequencies. SOE can be measured as early as 29.1 weeks post conceptual age, and the prevalence of SOE in healthy terminal preterm newborns is higher than the adults, and beyond 60 years the prevalence is decreases, even with hearing sensitivity is within normal limits. Daily and monthly changes. The frequencies of SOEs may change during the day, and the frequencies tend to be lower early in the morning or late at the night. And SOE frequencies are lowest immediately before menses and highest before ovulations. Hormonal influences on cochlear blood flow is possible mechanism. The race, African Americans have more SOE than whites, and Asians have more SOE than whites. Under pathological factors, ototoxicity, this will affect SOE frequencies, which tends to shift downward slightly during quinine intoxication, and it also affects interfering with outer hair cell motility, cochlear active processes, and alters potassium channel metabolism, also suspected. In sensorineural hearing loss, SOEs are not affected, which is less common in persons with hearing loss of any degree or even quite mild. Hearing is actually more sensitive in the region of SOEs. For tinnitus, SOEs are not recorded, and tinnitus symptoms, which is associated with cochlear damage, SOE reflects normal cochlear function. The transient evoked stimulus activates the cochlea simultaneously across a wide frequency region. If the cochlea, specifically the outer hair cell, is normal from the basal end of the basilar membrane to the apical end, then robust and normal amplitude TUE should be recorded from low frequencies up to about 5 kHz. Kemp initially called these emissions as stimulated acoustic emissions. In later studies, Kemp referred to these emissions as evoked cochlear mechanical responses or echoes, and Zwicker called it as delayed evoked otoacoustic emissions. Witt et al. Call it as Kemp echoes, and Rutten call it as evoked emissions. TEOE is recorded by placing a probe into the ear canal in a sound-treated room. If any ringing sensation or oscillation occurs, then the probe tip is not properly fitted. And the major four objectives are well-formed and clean temporal waveform with little or no ringing, flat stimulus spectrum, desired stimulus intensity, adequately low noise levels in the enclosed ear canal as documented by the device. So this is the picture of TOE recorded. The factors affecting TOEs, non-pathological factors and pathological factors. Non-pathological factors, prevalence in adults. TOEs can be measured in 98% of normal hearing ear, and if it fails to detect TOE, the causes are equipment related difficulties or subject noise problems. TOEs are detected in normal hearing infants or children, similar to those adults, and the amplitudes of TOEs infants is larger than the adults, and main frequency components may be higher in infants. TOEs in infants. TOE is ideally for screening hearing tests, and infants are the main subjective group, and the incidence of TOEs in neonates is same as in adults. Ear differences. TOE amplitude is more prominent for right than the left ear in adults and children. Genetics, it would be suspected that some families with more SOEs would show larger TOEs. Body temperature influences endocochlear potential mechanoelastic transduction properties of outer hair cell, length, shape and mechanics of hair cell and afferent synapses. Where the TOE amplitude decreases 1 dB SPL with every 1 degree increase in body temperature in normal. Increased temperature leads to more rapid deterioration of integrity of the outer hair cell. State of arousal and attention, TOE were independent of alertness level, and there's no change in amplitudes associated with sleep stages. Noise affects the OAE recordings and in three general sources: equipment noise, ambient environmental noise, physiological noise. Pathological factors, the external ear, where the stimulus intensity level may be below the target level and OAEs may not be detected if cerumen problems may interfere with OAEs measurement. Vernix caseosa is a fatty residue of amniotic fluid immediately after birth, and this will block the ear canal from microphone which records the OAE. In the middle ear, the amplitude is decreased for both positive and negative pressures. The negative pressure significantly reduces the TEOE amplitude. In TM perforation, if it is only a small perforation without any association of active middle ear pathology, OEs are recorded and the amplitude may be within normal limits across 500 to 8 kHz. OAEs are may be recorded in 50% of eustachian tube dysfunction. OAEs are rarely recorded in otitis media unless the airborne gap is less than 15 dB and amplitude is invariably lower than normal limits. In otosclerosis, OAEs are not recorded. Cochlear dysfunction, TOEs are abnormal or absent in subjects with tinnitus, noise-induced hearing loss, ototoxicity, outer hair cell damage, and normal OEs in malingerous attention deficit, psychogenic hearing loss, 8 nerve auditory dysfunction, central auditory nervous system, dysfunction, and Goveris et al. Found that TEOE is normal in 2 patients with vestibular neuritis. The advantages of TEOE is it can be used in neonatal hearing screening, and their presence indicates normal otoacoustic function, and the absence of TEOEs in subjects with normal audiometric thresholds and normal middle ear function is indicative of early cochlear lesion and intra-subject monitoring of changes in cochlear status, and it also helpful in differential diagnosis between cochlear pathology and retrocochlear pathology. But the disadvantages are it affects by noise, and when intensity levels are increased to very high levels, the distortion occurs and TOA responses is affected. Distortion product otoacoustic emissions are responses generated when the cochlea is stimulated simultaneously by two pure tone frequencies whose ratio is between 1.1 to 1.3, and the recent studies on the generation mechanism of DPOEs have underlined the presence of two important components in the DPOE response, one generated by an intermodulation distortion and one generated by a reflection. The pure tones which stimulates the cochlea are called primaries, and they are assigned as F1 and F2 for frequencies and L1 and L2 for intensities. The lower frequency tone is usually F1 and the higher frequency tone is F2. In order to generate intermodulation of DPOE component, the primaries should have frequencies close to each other. That is, F2 and F1 ratio is called as frequency ratio. And due to intermodulation, the cochlea generates a long series of components which are not present in the input stimuli. These components are called distortion products. And the most prominent and mostly used in clinical practice is the cubic difference distortion product, denoted as 2F1 minus F2. Generation of DPOEs are classified under two distinct mechanisms: nonlinear distortion and linear coherent reflection. DPOEs are also a combination of both generation mechanisms. The DPOE stimulus consists of two pure tone signals, of which frequency ratio varies from 1.20 to 1.22, and the amplitudes L1 and L2 values vary from 55 to 75 dBSPL. For screening applications, small frequencies are tested, such as 2 kHz, 3 kHz, and 4 kHz. The probe positioning is very important in recording TOE, and an erroneous position of the probe can block or it alters the shape of the DP graph. Usually an erroneous position results in blockage in one of two microphones which emits F1 or F2 tone. Interpretation of DPOEs, amplitude of DPOE is dependent on primary stimuli and overall health of the cochlea. In humans, DPOE amplitude is usually about 40 to 50 dB lower than that of primary tone levels. The frequency separation between two primaries is crucially important, and the relative frequency or ratio of higher frequency to lower frequency defines the separation between the two primary frequencies, and DPOE will not generated if these two primary frequencies are too far apart or too close together. Interpretation of DPOE is based on absolute amplitude, that is 3 dB for screening and 6 dB for diagnostics. Reproducibility, that is 50% lax criteria of screening and 80% strict criteria of diagnostics, and the signal to noise ratio is 6 dB. The factors affecting DPOEs: under non-pathological factors, ear differences, slightly larger right than left ear DPOEs, especially for frequencies less than 5 kHz, and the amplitude was significantly higher in ears with SOAEs. And age, DPOEs are higher for infants less than 1 year, and amplitude is greater for perinatal than prenatal infants, and the amplitude decreases during the 1 to 3 year age range and decreases even further for older children and teenagers until it reaches the adult values. If DPOE is abnormal in older adults, this results in reduced peripheral hearing sensitivity, and age does not affect DPOE amplitudes when hearing loss is accounted for. And in gender, DPOE is larger in women and decreases with increasing age, particularly at high frequency. Hearing level, DPOE amplitudes fall below normal region as the hearing sensitivity increases more than 15 dBHL, and the accuracy is predicted. Hearing loss was good at higher frequency except at 8 kHz. SOAEs, DPOE amplitude is enhanced in the frequency region of SOAE. The effect of SOAE on the DPOE is decreased when DPOE frequency is more than 50 Hz away from SOAE frequency. And ear canal acoustics, this DPOE influences more greater than 4 kHz, and as standing waves can occur affecting DPOE measurement and negligible below 3 kHz. Durational factors, DPOE amplitude changes at less than 1 dB with the time of day, and body temperature, as body temperature increases, deterioration of integrity of aorta hair cells are seen. And body position does not affect in DPOE amplitudes. State of arousal and attention, DPOEs are independent of alertness level and anesthesia. Ketamine DPOE amplitude increases up to 34% at all frequencies. Barbiturates induced negative middle ear pressure and reduces DPOEs. Clinical anesthetic or sedative agent has no apparent effect on DPOEs. Genetic factors, DPOE response will be seriously altered in selected genetic cochlear pathology. Measurement factors, probe insertion. Probe tip has to be properly placed inside the ear canal. Deeper is better, and proper size of the probe tip has to be selected. Equipment factor, as different DPOE instruments are acquired for applications, it was found that there were distinct and statistically significant differences among devices in DP amplitude. Noise affects OAE recordings in 3 general sources: equipment related, environmental related, and physiological related. Stimulus parameters, both intensity and frequency affects DPOE. With moderate intensity levels, L2 is less than L1, and the cochlea is mostly activated at the F2 place in basilar membrane. Pathological factors, tinnitus. DPOE amplitudes are lower in patients with tinnitus. Negative middle ear pressure, it influences DPOE measurements more than positive pressure, and for all frequencies tested. In otitis media, OAE responses are decreases as with the degree of hearing loss, and OAEs are abnormal in patients with flat tympanograms and hearing thresholds greater than 25 dB. Most children with middle ear dysfunction have reduced DPOE amplitudes or lack detectable DPOE responses. DPOEs are not detected in otosclerosis for any degree of hearing loss. DPOEs are recorded if perforation is very small and which is not associated with active middle ear pathology. And ventilation tube, DPOEs may be recorded if there is no active middle ear pathology and hearing sensitivity is normal. Further, the study tubes and grommets with DPOE is warranted, including DPOE measurement with high frequency greater than 2 kHz stimuli. Single frequency OAE are generated during the continuous stimulation with a single low level tone. SFOE is a technique which uses one or more sinusoidal tones as stimulus set and measure responses produced at the same probe frequency. They are thought to be reflected component from tonotopic set of the probe tone within the cochlea. Most frequencies are specific OAEs. The factors affecting SFOE: amplitude and growth function. The sound pressure levels of SFOEs vary between -20 and +10 dB SPL, and spontaneous emitting ears have slightly higher SFOEs. SFOE amplitudes in non-spontaneously emitting ears tend to decrease in higher frequency test range. Hypoxia, anoxia and ischemia. Limiting an animal's oxygen intake effectively limits the metabolic energy supplied to the ear. So brief hypoxia results in rapid reversible reductions of both the endolymphatic potential and the sound evoked cochlear potentials, including the compound action potential. Long-term hypoxia or anoxia results in irreversible functional losses and structural trauma to multiple elements in the cochlea. After effects of acoustic overexposure, if human ears exposed to noise for a long period of time, it results in temporary threshold shift, which also reduce the level of SOE, TOE and DPOE frequencies. Clinical applications of OAEs in adults, neonates and children. In adults, OAEs are used to monitor ototoxicity, noise-induced hearing loss, music-induced hearing loss, and differentiate diagnosis between cochlear pathology and retrocochlear pathology. ANSD, vestibular schwannoma, and it also diagnose endolymphatic hydropes, verification of pseudohypoacusis, patients who are difficult to evaluate with subjective procedure, identification of carriers of hereditary hearing loss, selection of candidates with cochlear implants, detection of central auditory disorders, and tinnitus monitoring. In neonates, neonatal screening, and for children, it's hearing screening, ototoxicity monitoring, tinnitus monitoring, and selection of children with cochlear implants, and detection of central auditory processing disorder. DPOEs in newborn screening, it will be judged as pass or fail based on the distortion product to noise floor difference. The frequency between 1 kHz to 5 kHz are usually tested, and DP amplitude was calculated. If the DP amplitude is 5 to 6 dB above the background noise floor, then that is considered as pass for that particular frequency. Monitoring cochlear function in ototoxicity. Because of their sensitivity to disruptions in metabolic processes within the cochlea, OAEs are extremely well suited for monitoring the cochlear function of patients treated therapeutically with potentially ototoxic drugs. DPOE abnormalities in ototoxicity, particularly for high frequency stimuli, may be detected prior to changes in auditory evoked responses and the pure tone audiogram. For noise-induced hearing loss, DPOEs are well suited as a monitoring tool because the frequency range extends up to and beyond the region affected by overexposure to noise. Music-induced cochlear damage, the excessive exposure to any sound will lead to shift in hearing threshold regardless of the sound is appealing, pleasant or annoying or obnoxious to the listener. In Meniere's disease, we can get two patterns of OAE, and the majority of patients with sensorineural hearing loss due to Meniere's disease, OAEs are abnormal, and the hearing loss greater than 25 to 30 dB, there is no OAE detected. Retrocochlear auditory dysfunction, the differentiation of sensory versus nerve-induced hearing loss can be identified by OAE measurement along with the audiological procedures and especially ABR. With purely retrocochlear auditory dysfunction, OAEs are normal. But the tumors in the internal auditory canal, as they grow and occupy more space, it impinges on the internal auditory artery and compromise blood flow to the cochlea. Clinical experience confirms that OAEs are abnormal or even not detectable in majority of patients with tumors. These are the references. Thank you for joining the webinar.